Can you hear me? Testing 1, 2, 3. Somebody please put in the chat whether you can hear me or not. Okay, thank you. Thank you, Rishi. I see that. Thank you. All right, let's get this thing started. I have 9:02 on my clock. Whoops. Sensitive mouse here. Good morning and welcome everyone to this training session on the pre-care plan care area assessment and care plan development process. For any first-time attendees, I'm Carol Eastberg, the RAI, MDS, and OASIS Education Coordinator for the state of Nevada, going on 11 years now. Prior to this position, I was on the survey team and participated in on-site state licensure, federal recertification surveys, and complaint investigations for about 6 different facility types for 7 years. A big concentration was in long-term care. However, I never worked in a long-term care facility. Just put that out there. If you registered by the deadline of 5 p.m. yesterday, and actually there were a couple that registered this morning, you should have received the slide handouts that I sent via email. If they're not in your inbox, please check your spam or junk folder. And I also included the links for Chapter 4 and Appendix C, so you'll be able to have those handy for reference as we go through today's session. As you locate and open those resources, I want to wish you all a very happy National Skilled Nursing Home Week, and thank you for your dedication and all the hard work you do to provide the best possible care for your residents. Also, I need to mention that this session is being recorded. Here's our agenda for today's session, and there's a good possibility that we'll finish before 12. As noted, times are approximate. I tend to speak fast, so we might get done sooner. All right, our objectives for today. After attending today's session, attendees will be familiar with all components of the care area assessments and care area triggers, understand what to do for each step in the process, know where to find needed supportive documentation, and feel confident in your ability to develop appropriate care plans. Excuse me. Here's our disclaimer for today. And by the way, as I mentioned, I've never worked in long-term care before, which means I've never actually gone through this process before. So I had to go through the material, read it very thoroughly, and try to picture what this would look like. And I also created, sorry, having to admit people in the lobby. I also created a partial MDS for our example resident. So go easy on me when it's time for that. As a reminder, CMS has several videos posted on their YouTube channel that you can watch anytime. And I strongly encourage you and your team to check out the CMS YouTube channel regularly for any new training videos they may post. Also, the video of this presentation will eventually be posted on the division's, YouTube channel. As usual, I will notify you all and provide the link when it's available. During our last session, we went over the changes in sections O through Q. I confirmed that clinicians and appropriate staff who are trained and deemed to be competent in doing so may complete sections of the RAI, including the BIMS, PH2Q, and PHQ9 interviews. We talked about the requirement for documented evidence of a diagnosis to be in the record in order to code it as active. And I provided information about completing a physician query for situations when the necessary documentation of an active diagnosis is not in the record. I explained that all MDS-related assignments the RN gives to the LPN require documentation of the same. We also noted that facilities are responsible for determining their own policies and procedures for these items. Before we get into today's topic, I'd like to go over the answers to a few questions received after our last session. Excuse me. The first question was, is hydroxyzine, also known as Vistaril, considered and coded as an anti-anxiety medication in Section N? Page N-4 of the manual indicates that medications should be identified by their pharmacological classification and not how they are being used. Since hydroxyzine is classified as an antihistamine, it should not be coded as an anti-anxiety, even though the physician may be prescribing it for the side effect of drowsiness for someone diagnosed with anxiety. Our second follow-up question was submitted by a licensed practical nurse who wanted to know if a registered nurse must oversee and sign off on all MDS sections completed by the LPN. Remember, according to the manual, a registered nurse must either conduct or coordinate each assessment. The RN assessment coordinator is responsible for ensuring sections completed by the LPN are an accurate and true reflection, regardless of the resident's multiple comorbidities. When the RN signs off at Z500, they are in effect swearing that all the information documented in section Z400 by other staff is accurate and true. For a link to the Nevada Board of Nursing's practice decision, which became effective January 19th, 2022, see the resources in the back of your handout. And I just want to mention here that all states have different requirements, and we're only talking about facilities in Nevada. The third follow-up question from the last training was a request for some templates or examples of GG functional, self-care, and mobility care plans. Remember, each resident is a unique individual with their own personal problems and issues, and while there may be some similarities in their diagnoses, regulations require that each one has their own customized, no cookie cutter care plans allowed. As I researched this process, I found only assessment tools. Then it hit me. The method for care planning hasn't changed, only the assessment items leading to the planning has. So we're not recreating the wheel here, we're just changing the way we inflate it. One of the sites I discovered during my research is called Nurse Together, which includes extensive information and care plan verbiage relating to diagnoses, how to create SMART goals, etc. What is a SMART goal, you ask? It's a goal that's specific, measurable, achievable, relevant, and time-based. First, a little background on why cause must be completed. Excuse The Omnibus Budget Reconciliation Act of 1987, or OBRA for short, mandates that nursing facilities provide all care and services necessary to help each resident attain or maintain their highest possible level of well-being. Each facility must ensure that their resident improves when possible, such as in the case of recovering from surgery or an accident that resulted in injury, and that they do not deteriorate unless it's unavoidable. For example, a chronic degenerative disease or a terminal illness. How can facilities comply with the requirements to provide the necessary care and services to help each resident attain or maintain their highest practicable well-being, especially when each one usually has multiple issues affecting them? For each resident, facilities must develop and carry out an individualized care plan, revise it as necessary, and evaluate its effectiveness on a regular, ongoing basis. Care plans are meant to be dynamic, not static tools to be reviewed frequently and updated as needed, depending on how the resident responds to plan interventions, along with any new issues that may appear. If a certain planned intervention is not producing the desired outcome, adjustments must be made. And of course, the IDT, or interdisciplinary team, or team, does not just make the changes and then inform the resident or their family of those changes. They must confer with the resident and their family or representative, if they have one, for their input and wishes about the plan. This slide includes an overview of the process, beginning with the assessment at the top and moving clockwise through all the steps. Today, we're looking at decision-making via the cause, followed by care plan development. Federal regulations require facilities to complete at a minimum and at regular intervals a comprehensive standardized assessment of each resident's functional capacity and needs in relation to certain specified areas, such as customary routine, vision, and continence status. The results of each assessment, which must accurately reflect the resident's status and needs, are to be used to develop, review, and revise each resident's comprehensive plan of care, which should then be followed and revised as needed. The team will use section GG to develop each resident's care plan with guidance generated by the cause. For whatever reason, the cause are not required for Medicare PPS assessments. They are only required for OBRA comprehensive assessments, as you see listed here on this slide. However, when a Medicare PPS assessment is combined with an OBRA comprehensive assessment, the cause must be completed in order to meet the requirements of the OBRA comprehensive assessment. In the resources at the back of your handout is a link to a tool that includes an algorithm similar to the rule of 3 to assist in determining the level of help needed now in section GG. And we know that section G, from which you used to get that information, went bye-bye. During the last 4 sessions, we went over the recent changes and coming updates to sections in the most current version of CMS's Minimum Data Set, or MDS 3.0. As you can see on this slide, the CAW process is one of 3 components that make up the Resident Assessment Instrument, or RAI. Even though it assesses the level of functioning of everybody's system, including psych, social, and level of comprehension, the MDS is not a comprehensive assessment according to CMS. The manual tells us that the MDS is a preliminary assessment to identify potential problems, strengths, and preferences, and that it is the starting point, a collection of basic physical, functional, and psychosocial information about the resident. Once the MDS has been completed, the collected data must be analyzed and combined with other relevant information to develop an individualized care plan for each resident. And this is where the cause come into play. The care area assessments, shortened to cause, provide the framework necessary to determine the resident's specific needs in the care planning process. They reflect conditions, symptoms, and other areas of concern commonly identified or suggested by MDS findings in nursing home residents, which flag or trigger responses to items coded on the MDS. When specific items are coded in the MDS, indicating a resident may have a problem or additional needs in that area, they are triggered to call attention so the IDT will assess and analyze each triggered area more thoroughly. The in-depth assessment of the causes and contributing factors gives the IDT additional information with which to develop a comprehensive, individualized plan of care for each unique resident. If you are new to this process, you may be questioning the purpose of the cause. In the manual, it tells us that when implemented properly, the cause helps staff to consider each resident as an individual with unique characteristics and strengths, affecting the individual's capacity to function. They identify areas of concern that may warrant interventions. Develop, to the extent possible, interventions to help improve, stabilize, or prevent decline in physical, functional, and psychosocial well-being in the context of the resident's condition, choices, and preferences for interventions, and they address the need and desire for other important considerations, such as advanced care planning and/or palliative care, including symptom relief and pain management. If you're wondering what triggers the care areas, so the IDT will know how to prepare a detailed care plan for each resident. Oops, sorry. Enter the care area triggers, or CATs for short, of which there are 20 total. Care areas are triggered by MDS item responses and indicate the need for additional assessment based on problem identification, known as triggered care areas or care area triggers, CATs. It's easier and quicker to say CATs than it is to say TCA. It's more fun too, especially if you love cats like I do. And there's my kitty cat Remedy. Hi, everybody. Meow. The CATs form a critical link between the MDS and decisions about care planning, and the manual provides guidance through every step of each process along the way. Interpreting and addressing the care areas identified by the CATs is the basis of the care area assessment process and helps by providing additional information for the development of an individualized care plan. This is Table 1 from page 4-3 in the manual, which shows all 20 care areas together. Just a quick visual for you. The general steps for processing the care area specific resources are shown here. Please save your eyes and refer to page C-3 in Appendix C of the manual while we go over each step. The document points out that these are general instructions for using the resources provided, meaning it's a good framework from which to start, and each facility can adapt them to their own needs. By the way, Chapter 4 in the manual is devoted to the CAW process and care planning, and I highly recommend that you read it in its entirety and reference as needed if you haven't already read it. Likewise, Appendix C is an excellent resource for developing care plans from the cause triggered in the resident's assessment. This resource should be used each time to ensure nothing is overlooked. I'll go over the details involved in each step, and then we'll go through the entire process with an example resident. According to the manual's instructions, once the MDS is completed, the first step of this process is to review all the MDS items and responses to determine which of the 20 care areas have been triggered and warrant additional consideration by the interdisciplinary team. As you do this, you'll be looking at both the MDS and Section V200A CAW results. Due to space constraints, this slide shows only the top half of Section V CAW summary item V200. Instructions for Step 2 are to check the corresponding box in column A for each care area triggered in the MDS. As the instructions point out, some of this information will be captured in the MDS and some will not. Even though all triggers are not clinically significant, you'll want to indicate each one that does trigger. After a thorough review of the record, you can indicate later in Step 6 if they are not being care planned and why not in the space provided in that section. During the review process, you may discover other care areas are triggered, in which case you would return to this section and place a check mark in column A for each additional area triggered. The next step is to determine which items in column A require care planning decisions. But first, where to find the information if it's not in the MDS? The medical record should have most, if not all, the information you need. Be sure to consult with the resident if possible and/or their representative as well. Also, you'll want to ensure you have the correct active diagnosis. Speak with the attending provider with any questions and/or for confirmation. Ensure each active diagnosis that needs to be coded in the MDS is documented in writing by the provider, and if necessary, initiate a physician query. Step 3 tells us that for each triggered care area, we need to conduct a thorough assessment using the care area specific resources. For this, we go to Appendix C, the CAW Resources section, which includes pages C-5 through C-84 and covers all 20 possible care areas. More about this in a few minutes when we look at our example. In Step 4, the team goes through each care area to see which of the 20 were triggered. Then, in the right column, indicate the name and dates of all existing supportive documents, including where the documents are located. This process of entering details regarding the location of documents used in decision-making is also included in Section V. So to ensure no important information is missed in either area, when you note it in one section, you might want to go ahead and note it in the others. Actually, there's more than one other. There's like 3 different places while you're still thinking about it. So if the resident does not trigger a specific care area, simply move on to the next. Step 5 is where you will document the results of your conversations with the resident and/or their family or their advocate. It may be a question or multiple questions they have asked and you have answered. Give yourself credit and document the details here. Find out from them any concerns they have in each of the triggered areas. They may even voice concerns about areas not previously triggered. In such a case, that area may need to be considered triggered. You'll need to investigate and determine how to care plan each of their concerns as needed. And sometimes a discussion might be all that's needed. It might not necessarily need to be care plan, but if they mention it, you'll want to document it. In the area provided, as shown on this slide, document all comments, concerns, preferences, questions, and suggestions, including who said what and the date and time, so that nothing is missed. If the field or the window in your software program does not expand to accommodate the response, be sure to indicate where in the record the continuation of these findings are located. This step needs to be documented for each care area triggered. Once you've completed steps 1 through 5, it's time to analyze your findings and document if a care plan is needed or not. As step 6 instructions state, this should include a review of all indicators and supporting documentation, including symptoms, causes, and contributing factors related to this particular care area. Document the team's description of the problem, causes and contributing factors, and risk factors related to the care area in the section titled Analysis of Findings on the left side. This process will be carried out for each care area triggered. Step 7 is where the team decides if referrals to other disciplines are needed, and documents the decision in the area provided as shown on this slide. This area is located directly under the Analysis of Findings and Care Plan Considerations section after each care area. If a referral is not needed, best practice is to enter NA to show that it was reviewed and no referrals were determined to be necessary. Step 8 instructions are to document in the Care Plan Considerations section on the right side whether a care plan for the triggered area will be developed or not, and the reasons why it will or won't be. If an area that was triggered needs to be care planned, indicate yes in the middle column and enter a brief explanation why this care plan is needed in the designated area on the right side. If the area was not triggered anywhere at all and no care plan is necessary for this area, indicate no in the middle column and document the reason in the designated area in the care plan consideration area on the right side. For step 9, you will enter the names and dates of all documents that show why a specific care area was triggered and the need for a particular care plan to be developed. On a side note, it's most likely that several of these steps will be done at the same time, or possibly even in a slightly different order. The goal is to be able to carry out each step efficiently and thoroughly to produce the best care plan possible for each resident, regardless of how many care areas they trigger. A note after step 9 points out that an optional signature date line was added to each checklist in case the facility wants the staff member who completes the transfer of CAW information to section V to sign and date it. Personally, I think it would be a really good idea for each IDT member to take on certain care areas in which they have targeted training and expertise and be responsible for reviewing the record for additional details. For example, PT and OT could take ADLs and functional rehab and falls. Documentation by nursing assistants would be especially helpful here since they work very closely with the residents while helping with ADLs. Speech therapy could take communication, which would include the swallow status. They could also review cognitive loss and dementia status. Dietary could be responsible for nutritional status, feeding tube, and dehydration fluid maintenance. Social services could be responsible for the psychosocial well-being, mood state, and behavioral symptoms items. Activities staff could review the residents' preferences for daily routines and preferred activities. and nursing could pick up the remaining 6 care areas. Now, don't misunderstand me. I'm not telling you that you must do it this way. I'm just observing what seems like it would be a practical approach. The division of labor needs to be worked out amongst the members of the IDT, and each facility must determine what works best for them. The process may even fluctuate depending on available staff members and other factors out of your control. Once each worksheet has served its function, it's a good idea for that team member to sign and date this form indicating completion of the process for each care area for which they were responsible, like the process carried out in section Z 400. At the bottom of page C-3 in Appendix C is a disclaimer indicating these resources are provided as a service to facilities and there is no requirement to use them. It is up to facilities if they want to use them or not, and they can modify them to meet their specific needs. You may have noticed that I switched the order of steps 2 and 3 because that just makes more sense to me. All right, let's go over our example. Mr. R is a 72-year-old gentleman transferred from acute care 10 days after a left-sided CVA. He presents with newly acquired expressive aphasia, short-term memory impairment, decreased strength on his right dominant side, a new inability to transfer and ambulate independently, and he developed a deep tissue injury on his right heel. He has a history of hypertension, atherosclerosis, O2 or oxygen-dependent COPD, and arthritis in both hands. The SNF admission orders are for skilled speech evaluation and treatment, skilled occupational therapy eval and treat, skilled physical therapy eval and treat, and skilled nursing to administer medications, monitor closely for medication side effects during titration of the meds, monitor vital signs, prevent the deep tissue injury from becoming worse, prevent the development of additional deep tissue injuries or pressure injuries, and he will need assistance from the nursing aides for instrumental activities of daily living and activities of daily living. Mr. R, a retired architect, lives in a one-story home with his very supportive wife of 50 years, along with their adult daughter and her 12-year-old son. The resident would like to return home, so social services will be involved to ensure the resident experiences smooth and safe discharge to home when it's time, and that any necessary equipment will be in place prior to his discharge home. Let's review Mr. R's MDS to see which of the 20 care areas will trigger. Obviously, I don't have a whole IDT or a few days to do this, so I'm only going to go over this process for one triggered area. Also, since I had to create this fictitious resident and complete the MDS, there are sure to be many elements missing that would normally be present. But I think you'll get the idea. Heck, you've done this before, and I never have. So your patience and understanding will be very much appreciated. I threw this in so you could see that this is both an OBRA admission and a PPS 5-day assessment, which means the cause are required due to it being an OBRA assessment. If it were just a PPS assessment, no cause would be required. And as I mentioned earlier, I don't understand that. Maybe someone can tell me in the evaluation section after our training today. Moving on to section B, we see that Mr. R is conscious, has adequate hearing without an aid, has unclear speech and difficulty making himself understood, understands others, has adequate vision with corrective lenses, and declines to respond to B1300, the question on health literacy. Per Mrs. R, he declined to respond to B1300 because he is embarrassed by his current inability to speak normally. Excuse me. In this section of GG 130, we see Mr. R's admission performance and discharge goals in the 8 categories of self-care. So his admission performance for eating, he requires supervision or touching assistance because he's having to use his non-dominant hand, which he never really used before. So he's rated or coded a 4 for admission. The discharge goal will be to be independent. The same is true for oral hygiene. Currently or at admission, he requires assistance from a helper, mostly not so much verbal cues, but more touching, steadying, and getting the toothpaste onto the brush with his non-dominant hand. Toileting hygiene on admission, he requires partial to moderate assistance, and the discharge goal is to be completely independent. In order to shower and bathe, his admission performance is substantial maximal assistance. The discharge goal will be to only have supervision or touching assistance. Upper body dressing, admission performance is a 2. He needs substantial maximal assistance. And discharge goal will be for supervision or touching assistance only. The same admission and discharge coding goes for G, lower body dressing. And as far as putting on and taking off footwear, he is dependent upon admission and hopes to be independent at discharge. Personal hygiene, he needs partial to moderate assistance. And I don't understand why the discharge goal is blacked out there. If anybody can tell me, that'd be awesome. Moving on to his admission, performance, and discharge goals in GG 170, mobility. These are the codes in items A through K. So here we see roll left to right, supervision or touching assistance is required. The goal is to be independent at discharge. Sit to lying is coded partial to moderate assistance, so the helper does less than half, but he does need assistance. Chair to bed transfer, same thing, he needs assistance, partial to moderate assistance. Car transfers, he needs substantial maximal assistance. Walking, you can see what the codes are there. And his discharge goals are all to be independent, just like he was before the stroke. Here we see the coding results for L through S, and I see that my alterations to this slide didn't take. Discharge goal would be independent for all of them. Of course, when you code a 10 here, you skip and go to the next one. He refused to try to lean over and pick up an object because it wasn't attempted due to medical condition or safety concerns. He is currently using a manual wheelchair, wants to be out of that by the time he is discharged. All right, step 2. Rather than flip back and forth to my fictitious MDS, I've included a problem list on this slide for convenience. As we review the REI, we'll indicate in column A which areas are triggered. Okay, My animations got messed up, so we'll just move on. Then we need to indicate each area triggered, whether or not it will be care planned. So in this example, I've identified 9 areas and we'll go through the process for each one of them. In Mr. R's case, I would check each box in column A that correlates to the problem list. So that would be cognitive loss, communication, ADL function / rehab potential, activities, falls because he's at risk for falls, nutritional status, dehydration and fluid maintenance, pressure ulcer, and return to community referral. So all of these were triggered. As I mentioned earlier, if during the review process you discover additional care areas that were not originally triggered in the MDS, you'll need to return to this section and indicate in column A each additional care area that is triggered. The next step is to thoroughly investigate the triggered areas to determine which items in column A will require care planning decisions and indicate that in column B, care planning decisions. But first, remember where to find the information in case it wasn't captured in the MDS. See slide number 22 as needed. Now it's time to look at the CAW resources in Appendix C for each care area triggered by Mr. R. The first care area triggered on this list is memory under number 2, cognitive loss dementia, which you will find on page C-10 of the manual or page 769 of the 1710-page PDF. Here we see just the first 3 pages nestled together. The team needs to go down the list on each page and compare the indicators listed with the coding in the MDS. If a condition is coded on the MDS, check the box next to it here. Additional documents to review include admission orders, history and physical, hospital discharge summary, lab results, transfer documents, and any other diagnostic reports to ensure the inclusion of all pertinent data. So you're looking at the MDS, but you're also reviewing the medical record for additional important information that's not necessarily included in the MDS, but affects the resident and provides valuable insight about the care they may need. Notice on the right side of each of these worksheets, there is space designated to enter the date and document name indicating where that supporting documentation was found. Entering all related details in the right-hand column each time will be very helpful for the team and state surveyors. The team will follow the same steps for each care area triggered for as many concerns as needed. And as I mentioned earlier, and I'm starting to sound like a broken record, while the team reviews all the documentation, they may need to check and process additional concerns as they are discovered. Again, it's a dynamic, not a static process. Next, the team indicates in the right column the rationale for checking the items in the left column. Also in the right column, indicate existing supportive documentation, including where the documents are located. And I'm pointing it out right now. Hopefully you can see my cursor going around and around that area. To ensure that no information is missed, you may want to copy and paste the info from one page to the other. And since I don't know what your software looks like, I could be just, this could be a moot point, but hopefully your software program has space for you to enter this information and it expands as needed. If it doesn't, be sure to indicate where the continuation of the supporting documentation is listed. Wait a second. So back to this slide 42, you can see here where the speech therapist completed this section right here, indicating where the supporting documentation is. And they also completed the assessment section. So they signed off here, speech therapy. Next, there's a section in which to document any input from the resident and or their representative regarding their concerns as it relates to that specific care area. Here we see Mr. R is normally very communicative and becomes frustrated and angry if his communication board is not always close by. And this section appears right after each area and needs to be utilized as intended. However, if neither the resident nor their representative freely communicate any questions, comments, concerns, preferences, or suggestions they may have, offer them the opportunity to provide their input. Ask if they have any questions, comments, concerns, preferences, or suggestions. If they have none, be sure to enter NA, showing that it was addressed and not missed or skipped. Now it's time to analyze your findings and put them in writing. This section comes immediately after the input field after each care area. As the instructions state, you will review all indicators and supporting documentation, including symptoms, causes, and any contributing factors related to this particular care area. Document the team's description of the problem, causes and contributing factors, and risk factors related to the care area in the section titled Analysis of Findings on the left side. This process will be carried out for each care area triggered. So in this case, we find that Mr. R has new onset expressive aphasia, status post-CVA. Pre-CVA, he was very articulate and communicative. His inability to communicate now triggers instant frustration and anger. And with that, it increases risks of exacerbation of the hypertension and subsequent CVA. In step 7, the team decides if referrals to other disciplines are necessary and documents the decision in the area provided as shown here. In this care area of communication, there's no need to order speech language pathology because this discipline was already ordered on admission. But you would definitely make a referral and document that decision here if needed. When a referral is not deemed necessary, best practice is to enter NA to show that it was reviewed and not missed or skipped over. In step 8, the team documents whether each area triggered needs a care plan or not. If the area was not triggered anywhere at all and no care plan is needed for this area, indicate no in the middle column and document in the designated area to the right. If an area was triggered and a care plan is needed, indicate yes in the middle column. Then enter a brief explanation of why this care plan is needed in the designated area on the right. So in this case, for Mr. R, he needs to avoid an increased risk of uncontrolled hypertension and additional CVA. Once you've completed step 6 and 8, your document will look something like this. Next, you will enter the names and dates of all documents that show why a specific care area was triggered and a particular care plan needs to be developed in the section titled Supporting Documentation. As I mentioned earlier, most likely several of these steps will be done at the same time or possibly even in a slightly different order than outlined in the instructions. The expectation, the goal, is to carry out each step efficiently and thoroughly to produce the best care plan possible for each area in which the resident requires care. A note after step 9 points out that an optional signature date line was added to each checklist in case the facility wants the staff member who completes the transfer of call information to section V to sign and date it. And earlier when I was going over the steps originally, I explained how each discipline, whichever section they end up completing in the MDS, would make sense for them to go ahead and go over the care area assessments and triggers and create the care plan along with the rest of the team and the resident and their caregiver or family member if they have one. So this section will either be checked yes or no, and then signed by the person and dated by the person who is responsible. Okay, Mr. R triggered care area number 5, ADL's functional rehab potential. This slide shows the 2 pages of assessment for this area. He had a recent hospitalization. He has communication problems. He has physical limitations such as weakness, limited range of motion, poor balance due to his weakness on the right side. He's at risk for falls, and he has a DTI on his right heel. There is a supplemental document found on page C-24 of the CAW resources to help you assess the various areas and help with the planning of a treatment program. I just discovered this late yesterday, but it does look very helpful. Looks like it would be very helpful. Here we see a couple of applicable items checked on the left side, hospitalization and communication problems, with the location on the right of the supportive documentations for the ADL. So we have a note pointing out that there's a 4/26/24 acute PT progress note and the 4/30/24 acute discharge summary. Regarding the communication problems, we have a 5/2/24 SNF admission H&P, a May 3/24 SNF SLP evaluation, and May 5th 24 MDS communication CAW. And here we see a couple of applicable items checked on the left: physical limitations, falls, and pressure injury, with the location of the supportive documentation on the right. So for physical limitations, we see again from the acute care facility, we see a PT progress note dated 4/26/24, so we would look in the record for that. There was an acute care discharge summary dated 4/30/24, so that's how we would know where to look for that. Excuse me. On May 2nd, the skilled nursing facility completed a physical therapy evaluation as well as an OT eval. So you would look in the chart on those dates in that section for those documents to get that information. The supporting documentation for falls was dated 5/2/24, and that was a skilled nursing facility PT evaluation. And then here you see the supporting documentation, location, and dates of the documents for the pressure injury. Mrs. R spoke up on behalf of the resident regarding his normal ability to be independent with ADLs almost all the time. So the person documented, per spouse before CVA, Mr. R was independent with activities of daily living and only occasionally needed assistance due to the pain and moderate deformity caused by rheumatoid arthritis in both hands, but especially the dominant right hand. And he doesn't want to be a burden to his family. As we analyze Mr. R's deficits in the ADL area, we see he becomes frustrated at having to depend on others for assistance with activities in which he has always been independent. So that will require a care plan. According to the analysis of findings, he has a new onset right-sided upper and lower extremity of the dominant side, status post CVA. Excuse me. Now needs substantial assistance with ADLs. Frustration related to dependence on others for help results in the risk of hypertension exacerbation and a subsequent CVA. Mr. R will have a robust care plan for ADLs and functional rehab so he can return to as close to his former status of independence as possible. And we see here in the care plan considerations, full therapeutic efforts to return to pre-acute care level of function will be care planned. Resident is very motivated and family is 100% supportive. Again, we see steps 6 and 8 side by side, this time for ADLs. So we see he's at risk for HTN exacerbation and a subsequent CVA due to frustration, excuse me, with being dependent for ADL assistance. He was formerly 100% independent. And the care plan considerations indicate full therapeutic efforts to return to pre-CVA level of function will be care planned. Resident very motivated and family is 100% supportive. Excuse me. Wow, we're at the recap already? I feel like I left something out. Anyway, today we reviewed the 3 components of the RAI, the cause and the purpose they serve. We went over the care area triggers and the part that they play in the process. We went through the call process step by step, explaining multiple nuances along the way. And lastly, we went through the process for one care area with an example resident. Actually, we went through 2, communication and ADLs. Many of you, if not most, have been carrying out this process for some time. So I kind of feel like I'm preaching to the choir here and not very well. Also, as I already mentioned, I've never actually had the opportunity to complete a real RAI or a CAW. And the last time I prepared a care plan was probably back in 2003 or 4, and that was in home health. Excuse me. So now I will open it up for questions, and I can't guarantee I'll be able to answer them, but we'll give it a shot. Hold on while I unmute all of your microphones. And don't plan on speaking, please mute yourself. Huh. Okay, it looks like everyone should be unmuted. you want to raise your hand, I'll call on you and see what's what. I hear somebody. Sounds like a mouse scratching around. Oh, thank you, Carrie. Carrie, I see your response to my GG0170. Okay, cool. Looks like she left.
Oh, sorry, Carol. I'm still here. I just had to switch to my cell phone.
Okay,
but I'm
no
here.
worries. Okay, no worries. Thanks for letting me know.
Yeah, you bet.
Okay. Does anyone have any questions? Speak now or forever hold your peace. No, you can always ask a question in the evaluation form if you don't want to speak up during this time. I understand. Okay, well, I guess we'll move on to the post-test and evaluation. Let me shoot those off to you in an email real quick that I've already got prepared. And I just want to say thank you to everyone who attended today. So you should have received the email with the post-test and evaluation. After everyone has had an opportunity to complete the post-test and evaluation, we will go over the responses together. Paula, I see you have your hand up. Paula, do you have a question?
Yeah, I just wanted to, I haven't received that.
You haven't received the... Check your sent email because it might be in there. For some reason, it doesn't let you know that you submitted, but it lets you know that you weren't able to submit it. Did you check your sent?
Yes.
Oh, you know what? Okay, I may have messed up on that. Here. Hey, Paula, can you hear the music playing? I'm sorry?
Yes, I can.
Oh, good.
Type in the chat box and I still.
I've been having trouble with Adobe Acrobat lately, and I don't know what happened here. I'm trying to figure it out.
Carol, I was able to get it. This is Sheila. I was able to get it, complete it, but it won't allow me to submit. Can I save a copy and send it to you?
Sure. I think because I'm using the template that I used before, I may have needed to go in, and I didn't double check to see that the email was, it should have stayed the same as it was last time, but for whatever reason. You can copy it and yes, scan it or whatever, however you need to get it to me, that's fine. Is anyone else having trouble submitting?
Hey, Carol, this is Hope. I'm not able to submit as well, so I'll just scan it to you.
Okay.
Thanks, Carol.
Thank you. Well, I just checked and the email is still there, so I don't understand why you guys are having problems, but I have problems all the time, so. Sheila, I got your email with the subject test care plan cause, and the document is attached, so that's great. Yes, the others are coming in just the way they're supposed to. So it must be the people who were not able to submit it. It's on your end. Everything is good on this end for once.
Carol, this is Wanda. I just sent an email with the attachment to you.
Okay, Wanda, thank you. Okay, is there anybody who has not had enough time to finish or wasn't able to open the document for whatever reason? What's going on? I hear crickets, but I don't see a lot of PT&Es returned. So far I have 1, 2, 4. I only have 4 returned.
I just said. Hi, Carol. This is Brenda. I just had to email mine too because I can't submit it.
Okay. So
Thank
far
you.
I have one from, you're welcome, Shannon, Lisa, Robin, Sheila, Carrie, Paula, Aaron. Jessica. Brenda, I just got yours. Thank you. Tonya, I just received yours. Thank you, sir. Thank you, Rhonda. Paula, I see your hand up. You have a question? Actually, you raised it twice, it looks like.
Well, I never did get the test and I can't type in the box, so I just, I can't do anything.
You never got the test, but you can't, how can you not type in it if you didn't get it?
I can't, that's what I'm telling you.
Huh.
I'm paralyzed, I can't do anything.
Okay. I'm thinking. How about if in an email you just write 1 through 10 and put true or false next to it?
Okay, I can do that. If I have the
Okay.
test, but I don't have the test.
Oh, okay. I thought you said you had the test, but you didn't.
No, I never
That's-
got the test. That's why I
Oh.
raised my hand initially, because I don't have it.
Okay, I'm sorry. Do you have a different email than what I've got on record for you?
Yeah, well, you know, you sent it to my original email and then our company got bought out. So I answered it with my new email at mds@fallonrehab.com. So I wondered if that was part of the problem. But they
Whatever you
answered me.
registered for with, that's what I used.
I registered with my new email.
Huh. Okay, mds@fallonrehab.com.
Uh-huh.
On its way. Sorry
Thank
about
you.
that. You're welcome. Thank you. Somebody else had their hand up. Does anyone else need the post-test and evaluation sent to them? Redeem, you still have, and Angelia, you guys haven't received it? If you're unable to submit, sorry, Brenda, I see where you say it never works for you. Can you save it and then attach it in an email? Yes, Bina, this is for MDS. Okay, Redeem, I see that you got it. Well, there's 39 people attending and only about 22 post-tests have arrived yet.
6.
I hear your frustration, whoever that was. It just let out a big sigh.
Oh, sorry. That was me. I finally got the test, but it won't let me click on an answer or anything. So I'm just going to type in my answers 1, 2, 3, 4, 5 and send it back to you.
Okay, I'm sorry. It's the story of my life every
Yeah,
day.
well, it never works for me either. I was laughing when you said that about that other gal, because I'm like, yeah, I feel you.
Oh my gosh. Every day my computer crashes and whatnot, and it's
Oh,
just
Lord.
ridiculous.
Carol, I'm actually just scan it to you right now. It just won't let me post it or email it. So I'm scanning it to you right now. Thank you.
Okay, thank you. Elaine, I see your email regarding the hydroxyzine coating on the 672. I will look into that and get back to you.
Thank you, Carl.
Welcome. Okay, let's go over the answers, everyone. The first question asks, or actually states, CAUS are not required for Medicare Part A PPS assessments, true or false? The answer for that one is true, although I don't understand why. And now that I'll have time to look into it, I will research it thoroughly because inquiring minds want to know. Number two, excuse me. When a Medicare Part A PPS assessment is combined with an OBRA comprehensive assessment, CAUS are required, true or false? And the answer is true. When CAUS are required, it is due to the passage of the Crow Preservation Act of 1987, true or false? That one's false. The RAI is made up of 3 components, of which the MDS is one and the manual is another. True or false? True. The CAW process is a focused investigation to determine if triggered items require planned interventions for a resident's unique care needs. True or false? That one is true. CAWs help the IDT determine what they want the resident to focus on during their stay. True or false? That one is false. It's what the resident wants to focus on. CATs help to identify which of the areas triggered in the MDS need to be reviewed and possibly care planned. True or false? True. Interpreting and addressing the care areas identified by the CATs is the basis of the care area assessment process. True or false? That one is true. All pertinent information necessary to make care planning decisions will be located in the MDS. True or false? That is false. And the last one, the checklists and processes outlined on page C-3 are required to be used by facilities for care planning purposes. True or false? And the answer is false. They are optional. Please fill out the evaluations. I really appreciate your honest feedback. If you have a question, I'll be happy to answer it via email after I make my way through all of them. Your CEUs will be prepared and distributed as time allows. Usually I think I've gotten them done within a month, but the goal is to have them done a lot sooner than that. It just depends on my workload. Does anybody have any final questions before we sign off? And I'm going to give you back an hour and a half of your day. Yes, Carrie.
Oh, hey, so I was just going to mention that the cause aren't due with a PPS 5-day, just because that's done for billing specifically. So they're only required if we have to do an OBRA comprehensive admission as well.
I get that, but wouldn't they need a care plan anyway, whether they're going to be there for 5 days or 2 months? I don't get that.
Right. So the reg says that a comprehensive care plan has to be completed within 7 days of that sign date of the OBRA admission. So if they leave prior to day 14 and don't need an OBRA admission comprehensive completed, they technically don't need a completed comprehensive care plan in their record. Best practice is to start the care planning process, right? Best practice, like our company, we start discharge care plans basically on day of admission, right? But I think the reg says that that baseline care plan that we do on admission that's good for 48 hours is technically sufficient. But I wouldn't recommend just having that.
Right. Okay.
So then you would be care planning just based on knowledge of the resident, right? The medications they're taking, their diagnoses, any behaviors we see in those first, prior to day 14.
Yeah, kind of their immediate needs. But to me, it just,
exactly.
The way I read it, and I take things literally, is like, you don't need a care plan for them. And I'm like, well, yes, you do.
Right. And I think a surveyor would say, well, yes, you do. Right.
Exactly. So yes, that's where I'm coming from.
The reg. Yep. The reg and the real world, I feel like, are on different pages.
Yeah.
But I will say, for Medicare patients, it does save a lot of time not to have to do the care area assessments if they leave prior to day 14.
So what process would you follow then in that case? I mean, you don't know if they're going to stay that long.
So most of our patients are short-term rehab. So we usually do know that. Sometimes it's insurance driven, right? They're only authorized for a set amount of days.
Yeah.
And so we know they'll be gone by day 10. So then that just changes our process a little bit.
Okay.
But our best practice is, unless we have a definite discharge date prior to day 14, we just combine the admission OBRA with our PPS 5-day and do the process all together.
Gotcha. That makes sense. To me, that seems like the best way to do it.
Yeah, it works pretty well. Sometimes it's a little extra work because you'll have somebody leave prior to day 14, but I'd rather have a little extra and make sure it's in there than have to go back and add it in.
Exactly.
And Carol, this is Sheila. We have both long-term and short-term in our buildings. And what I find, and this has been forever, but especially since they've really been mandating the baseline, we actually have a baseline that is initiated in that first 48 that gives the basics. Then as things are being identified during the days, even if we think they're going to be short-term, we go ahead and start adding care plans. So you may see their discharge care plan, you may see their code status care plan, you may see their fall care plan already initiated. It just won't be the full comprehensive that we have done. We have done everything, all the interviews, all the assessments, all of the MDS and the cause and everything to have done the full comprehensive care plan. But at least in our practice, we start with our baseline and then we start adding as the days go by in our clinical meetings and so forth.
That sounds exactly like it should be. Yes. Thank you, both Carrie and Sheila, for speaking up. Like I said, I've never worked in long-term care before, so yeah. Anyone else? Okay, well. Hi, Angela. Oh, you're welcome, Nadine. Thank you, everyone, for joining us for today and putting up with me. I appreciate it. Have a great rest of your day, and we'll see you next time. Take care.
Thank you.
Thank you. Bye-bye.
Thank you.
Thanks,
Carol.
Carol.
Appreciate it.
See ya.
Thank you.
Carol.
You're welcome. Thank you.